Hi, I'm Dr. Martha Gulati. I'm the Chief of Cardiology at University of Arizona in Phoenix and the Editor-in-Chief of CardioSmart for the American College of Cardiology. I'm here at the American Society of Preventive Cardiology, where I was able to give a keynote lecture, the Nanette Wanger Lecture, here at this meeting. And I spent a lot of time talking about, first of all, Dr. Wanger's contribution to women and cardiovascular disease. She really said many decades ago, actually, that women were essentially ignored when we came to heart disease. We would talk about everything else, the reproductive system, the breasts, but ignore a woman's heart. And here we are many decades later, and still, to some degree, we've ignored women's hearts when we're talking about women's health. There's still an overt focus on breast cancer funding from the NIH. Certainly, there's more funding for breast cancer research than there is for heart disease, specifically for women. And so I outlined some of the reasons why women still don't do as well after they have a heart attack. We do know that after a woman has a heart attack, she's less likely to get medications in a timely manner, less likely to undergo revascularization, and as a result, more likely to die. I also outlined that there's some differences in how women present, and sometimes their symptoms may be delays in care. But we also have newer data on younger women showing actually 90% of at least women under the age of 55 still do have chest pain. The difference between men and women in the younger population is that women often have 3 or more other symptoms that are present at the same time. And my question really is if we're not asking the right questions, or we're missing the word chest pain or whatever their symptom is that makes us know that they're actually having angina or ischemia, because we're focused on the other descriptors that they might provide us. So further down in my talk, after I talked about a little bit of the differences related to how we present and how we treat, is also the differences between the pathophysiology of ischemia. And we've traditionally thought of ischemia as an obstructive lesion, and I think that's really been a little bit of the barrier to how we approach women, because women are more likely to have non-obstructive disease, but they still have signs and symptoms of ischemia that can't be ignored, and what brings them to the hospital or to their physician asking what's going on. And so I think, of course, there's still more work that needs to be done in this area. We don't have all the answers at this point about how best to treat them, but certainly if you believe that they're having ischemia, you have documented ischemia, we should be treating them like you would treat someone with ischemia. Now the whole area is going from, thinking about ischemia at less as obstructive, but rather as a continuum. And there might be many different pathways of this idea of ischemia with no obstructive coronary disease, or ANOCA as we have called it. And I think that there's a lot more work to be done in this. I don't think it's just one disease process, but we will have to figure that out with more research in this area. I think the other thing that's really important for preventive cardiologists is to focus on the unique issues related to women and risk factors, specifically risk factors that appear during pregnancy, like preeclampsia or any form of gestational hypertension, gestational diabetes, preterm delivery. All of those are risk factors for cardiovascular disease, and their risk for heart disease is pretty early for them. So you really do need to be asking them when you're taking a history or an inventory of risk factors. And I think that, again, recognizing that men and women are different, and there's some unique questions you need to be asking women and paying attention to them, because, of course, heart disease is the #1 killer of both men and women.